Now, chronic leukemias are much different because chronic leukemias, the cells are much, much more mature. Chronic leukemias, the cells are much, much more mature. Since those cells are much more mature, you are able to fight off infection much better. These cells for chronic leukemia, first of all, the cell count is always up. By definition, in chronic leukemia, the cell count is always up. By definition, you never get low cell counts in a person who has got chronic leukemias. They're always up. The next thing is these leukemias kill you much slower because these cells are working. These cells are fighting infection. These cells go to work in the morning, they have a job, bacteria comes in the body, pneumococcus comes in the body, they get up and they kill them. Whereas acute leukemic cells, between diagnosis and death is 6 to 12 weeks without chemotherapy and a bone marrow transplant. You get diagnosed now and you'll be dead before your step 2 result comes out. Whereas when you have a chronic leukemia, chronic lymphocytic leukemia, which stage 0, which is just an elevated white count, or stage 1, which is a elevated white count and positive lymph nodes, these between diagnosis and death is 10 to 12 years. So it's 10 to 12 years before these will kill you. So therefore, these cells are much, much, much more mature. They're not fully mature, but they're much, much more mature. When you get a big spleen from the cells, that mortality goes down to about 5 years of survival. And by the time you get to more advanced stage disease, like having anemia or having a patient who's got thrombocytopenia, such as decreased platelets, the mortality has gone to 1 to 2 years average survival. So early stage disease, you can live for a decade. And since the average age of onset of the disease is in the late 60s or 70s, most of these patients don't need to be treated. Because if you're 70 years old and you have a disease that's going to kill you when you're 82, what's the point in giving chemotherapy for early stage disease? Now, this is the only disease in oncology where the staging starts at stage 0. Nothing else starts at stage 0. This is the only one. All of the others are going to present with a much later stage, where just by nomenclature, calling it stage 1, 2, 3, 4, A, B, C, D, but only CLL starts their staging system at stage 0. Nothing else starts at stage 0 as a matter of nomenclature and classification. This is unique, unique. The reason being, just elevated white count by itself does not require therapy in the majority of patients. It's just an abnormality that requires no therapy. 6 to 12 weeks between diagnosis and death? Here might be 6 to 12 years, even without therapy. Even without therapy. If these patients present with advanced stage disease should be treated with fludarabine. Now, chlorambucil is a second-line drug that is used just to palliate people. Chlorambucil. Chlorambucil does not extend anybody's survival. Chlorambucil is just like going to get a haircut. It doesn't make you live longer. It doesn't stop your hair from growing. It just stops the external manifestation. Chlorambucil and prednisone is old therapy for CLL that was basically given to just drop the white count. That's all. You treat people with CLL if they have 1, advanced stage disease, or 2, they're symptomatic. Any patient where it says, I got a big spleen, I'm in pain, I'm feeling so tired, I'm incapacitated, and you have a high white count on these other advanced diseases, you can't leave people being symptomatic. Anybody who's symptomatic gets fludarabine. The other caution is that anemia could be Coombs positive. So if the anemia is Coombs positive, the treatment for that is steroids if they have Coombs positive anemia. Not just anemia from the spread of the disease. Anemia from the marrow getting replaced, chemotherapy, clean up that marrow. Anemia from Coombs positive hemolysis, the answer is treat the hemolysis. Now, chronic myelogenous leukemia. Let's see. We got a 47-year-old man who comes to the office because he is tired. And he's found to have 58,000 white blood cells. What would you do first? The answer is a differential. If the differential shows that this guy is greater than 90% lymphocytes, this is CLL. Now that's very unusual at 47, but it could happen. The main thing is not the age. The main thing is how are they presenting. So therefore, when you have a person who's got a very high white count, the first thing to do is their all neutrophils or all lymphocytes, greater than 90% neutrophils. Now, once you know that you have a very high white count, that's all neutrophils, the next thing to do is to say, is this leukemia or is this reactive? Is this leukemia or is it reactive? Is it leukemia or is it like leukemia, leukemoid? Do you have erysipelas, skin infection, or do you have a skin infection that's like erysipelas, erysipeloid? Do you have a syphilitic chancre? Or do you have something that's like a syphilitic chancre, chancroid? Do you have carcinoma? No, I've got a much more benign disease called carcinoid. Are you a man? Or are you a machine made in the image of a man? Android, humanoid. So is it leukemia or is it a leukemoid reaction? And what you use to distinguish those is a leukocyte alkaline phosphatase score. If the leukocyte alkaline phosphatase score is low, it's leukemia. If the leukocyte alkaline phosphatase score is high, it's leukemoid. And the reason for that is that leukemic cells have normal amounts of secondary granules. The primary granules are for myeloperoxidase, and they all have it. But the secondary granules happen only in a mature cell. That is alkaline phosphatase. Here, the cells are up in number, and the cells are up in function. They are the warriors. They are the military for your bone marrow going out to attack. Infection invades, they attack. Abscess, they attack. High in number, high in function. Leukemia, they may be high in number, but they're low in function. Now, one of the other things that is going to give you a clue to CML is the presence of an enlarged spleen. Although you can have an enlarged spleen as part of CLL, splenomegaly is much less common. It happens later. CLL starts out with white count. Then it spreads to the nodes. Then it spreads to the spleen. Then it invades the marrow. Then it might just crowd out the platelets. But CML, chronic myelogenous leukemia, presents with a big spleen as part of the disease much more often. Big spleen means abdominal pain. Big spleen means early satiety because the spleen is pressing on your stomach. Wow, I have 4 bites of a turkey burger and I feel full? Why do I have 4 bites of a turkey burger and I feel full? Because you've got a big, huge spleen the size of a 2-gallon bucket pressing against your stomach. Oh, no good. Abdominal pain, early satiety. That's a clue to CML. Now, CML can convert to acute myelogenous leukemia. That a conversion to the blasts of acute myelogenous leukemia is called a blast crisis, for obvious reasons. It's a crisis when you start blasting off into acute leukemia, because when you do, you may very well be dead before the end of the year. 20% per year convert into acute myelogenous leukemia. So the management for CML is to treat the disease before it develops into acute leukemia. How do we get the disease under control? One, we confirm it, the diagnostic test, with the presence of the Philadelphia chromosome, which is the translocation in our genetic structure. Next, we use a medication. You ready? Here it is, brand new. Whoop, 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 whoop. New information coming in. New information coming in. Imatinib. Oh my God, what an unpronounceable word as imatinib. You are kidding me. I got to memorize an unpronounceable word like imatinib? Yes, I have to memorize an unpronounceable word like imatinib because this drug results in a 90% improvement and has no side effects that are significant and is oral. Ding, 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 ding. Gleevec, imatinib. Welcome to the greatest wonder drug in oncology in the last 10 years. This Philadelphia chromosome codes for a tyrosine kinase. The tyrosine kinase is an enzyme that drives the disease. Imatinib blocks the production of that hormone. You get a condom on that Philadelphia chromosome and the disease stops. 90% improvement. 60% of people get rid of their Philadelphia chromosome. What are the wrong answers going to be when Gleevec is the right answer? Interferon will be the wrong answer. Interferon you had to use for a year to get a 10 or 15% response. Here, everybody gets some sort of response, 60% Philadelphia chromosome, no side effects. Interferon is like feeling like you got the flu for a year when you treat them. You know when you have the flu and you got aches and pains and headache and a cough and you feel irritable and don't touch me, don't touch me. Leave me alone. You just want to shuffle around your house and cough. That's interferon in your body. That's your body's fighting off an infection. Your body's making interferon. You feel crappy and lousy and irritable. Now we take about 1 million times more than that and pour it into your body, and it's like having the worst flu you ever had. But it beats death most of the time. Imatinib, Gleevec, 90% improvement. Hydroxyurea has one function. That is to drop the cell count down. Hydroxyurea is like going to the barber. It's just to shave. Imatinib is a waxing or laser hair removal. Hydroxyurea is just shaving. It lowers the cell count, but it doesn't stop the growth of the problem there. So therefore, you should use this one first. Hydroxyurea lowers the cell count. Interferon and busulfan will always be the wrong answer. Now the question says, what therapy for CML is most likely to cure the disease? Cure. Sustained remission. Bone marrow transplant. Because although imatinib may get rid of the Philadelphia chromosome, 60%, it's not a cure. When you stop it, it comes back. It's like treating diabetes. When you get your sugar under control when you're diabetic, you have not cured the diabetes. Bone marrow transplant is the only way to get rid of the disease entirely. So therefore, the bone marrow transplant is the only way to eradicate it. And you do it before they blast off. CLL, you can't transplant CLL because these patients in general are 65 years old. And you can't transplant a 70-year-old with an allogeneic transplant because allogeneics have to be under the age of 50. Over the age of 50, the mortality from a bone marrow transplant shoots up and they die from the transplant. The same way, if you have a 22-year-old baseball player who fractures his hip, he recovers almost always. If you're an 80-year-old little lady and you fracture your hip, it'd be better to have a myocardial infarction. The mortality at a year at a myocardial infarction is about 10 or 20%. The mortality at a year for a 75 or 80-year-old lady with a hip fracture is about 60%, maybe more. It'd be better to have a myocardial infarction, a heart attack, because older people just don't recover. As we get older, our ability to recover diminishes. As we get older, we can't do a bone marrow transplant. No allogeneics over 50. Allogeneics have to be under 50, so the bone marrow will recover. Autologous, you can go to 60, and with stem cells, you can do it as long as they're under 70 years old, because there's no rejection, there's no graft versus host disease. You're just giving a concentrated version of themselves back. Concentrated me. I'm a narcissist. Maybe I'll do this now. Stem cell transplants, giving concentrated you back to yourself. You can go up to 70 with that. Above the age of 70, people generally don't recover. CLL, if it's advanced stage disease or any symptomatic disease, treatment with fludarabine and prednisone. If they're too old, too fragile, too sick to withstand the fludarabine, a 92-year-old, just a palliation, gets chlorambucil. CML, imatinib, ding, 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 warning, warning, danger, danger. Advancement through, 90% clinical improvement, 60% Philadelphia chromosome, no adverse effects. Terrific drug. You find a high white cell count, the LAP score is low, and the Philadelphia chromosome is positive.